today focuses on inflammation, metabolic syndrome, and disorders of actually not just so much disorders, but we're going to focus on primarily things on how inflammation and the metabolic syndrome work together. When we do these things, we, as clinical individuals, we have patients that have questions regarding why they're hurting so much. So our goal today is to kind of bring in one of our diagnostic protocols that we particularly do in our office. And by no means is this the final list. We have just a conglomeration, but it lets you kind of see that we not only look at the body in a biomechanical way, but we also look at the body in a physiological way. So my goal here is to bring an open forum conversation in terms of how we assess metabolic syndromes, how we assess inflammation. Now, as you guys know, over the last couple of months, we've been talking about inflammation and how it affects each or pretty much all the body systems in some sort of capacity, whether it's the neurological, whether it's the digestive, whether it's the endocrine system, whether it's the skeletal system in some sort of joint inflammation area. So what we're going to do today, we're going to figure out at least some of the markers that we're using. I'm going to have Anna, she's going to be discussing an area which is going to cover the metabolic area. We're going to be covering the markers in the blood markers and try to make sense of some of these things. Now, as you'll see, there's a big picture to the process. So what I'm going to do is I'm going to share my screen right now so that we can kind of start the conversation as to how we'll be discussing it. So in this particular area, we can see here, and can you guys see that okay? Yes?
Yes, we can see it.
Okay, so we can see regions of how we assess the metabolic processes. And what we do is not only do we do, when a person comes in, a personalized history, we also measure anthropometric measurements like body composition, body densities, muscle mass indexes, BIAs, BMIs. We basically have to assess the body in a lot of different components, but not only take a big history, but we also want to figure out what's going on in the blood system, because there's a lot that can happen even though we don't know. Family history gives us an insight to the direction we want to go in. So today we're going to be discussing, particularly in our direction, we're going to be discussing things such as metabolic markers and inflammatory markers. So what we're going to do is we're going to study these particular dynamics, and from there we'll be able to add some clinical insight to that. So Anna, are you going to be able to, can you present your screen at this present time?
If you can make me a co-host,
yes, I sure will. The world of you're going to be allowed to be a co-host right now. So co-host is yours. So everyone knows what a co-host is now. I think in Zoomlandia. So Anna and Kenna, both of you guys are co-host at this. So at any given time, I'm going to stop sharing mine, and you can start sharing yours at any given time.
Okay.
Now, as you do that, we're going to be discussing some real cool inflammatory markers. I have some real good insights as for F2 isoprostane. We're going to be talking about. We're going to about oxidized LDLs and more. So I look forward to being able to discuss those things. Anna, go ahead, take it away.
Okay, so we can see now. You can see my screen now.
I sure can. It's a good screen.
Okay, that's awesome. So now we can see here is the wellness, an approach to optimal wellness. And we can see right here what Dr. Jimenez already mentioned, that inflammation is right in the center of it all. And it can actually access or affect a lot of metabolic markers, lipid markers, hormonal markers that we might want to look at in order to assess the patient's health. So I'm going to talk about the metabolic situations or the metabolic assessment that we might want to go into when we're talking about the optimal wellness of the patient. So of course, we're going to have glucose. But if I might say so, something about glucose is that it's not like the primary thing that we're looking at, because as we mentioned before, we're thinking in a functional medicine kind of approach. So the glucose marker will always be like a kind of monitoring marker that we're gonna kind of look at just to see what is the snapshot of the patient right there. So yes, it's very important for the here and for the now, but I might want to take like a little time to talk about the other metabolic situations or about the other metabolic markers that are going to ultimately affect the glucose markers, and like to like take it into
Absolutely.
like the final step. I think thinking as a function with a functional medicine approach, glucose is great, it's to monitor, but let's not start there. Let's not stop there. That's like the main thing that I want to make sure that you understand. Well, that everyone understands. So one thing that we are going to look at is the insulin and the oral glucose tolerance test. So we all know that while inflammation is going on, our insulin sensitivity is going to go down and down and down. So that is going to affect our glucose, and therefore an oral glucose tolerance test is going to be needed. But let's go like a little bit deeper and deep down inside of it. We will have this special metabolic marker that is called adiponectin. And I want to know if you've ever like heard about adiponectin before?
Absolutely. We run this all the time.
Well, yeah. So adiponectin is actually secreted by the adipose tissue. It is mostly secreted by the white adipose tissue, but it can be secreted by the brown adipose tissue as well. And it's one of the most important circulatory adipokines that we can have in our body. But let's think about it for a second. Adiponectin has 3 different isoforms. So it has like the high density adiponectin, low density adiponectin, and medium density adiponectin. So what studies have found is that the high density adiponectin is the type of adiponectin that will have like the most anti-inflammatory effects. So this is very important because it seems to act as an anti-inflammatory, and it can act on insulin sensitivity. So this is one of the first markers that I would like to address. Something else about adiponectin is that it is actually linked to, well, it can be like a protectant, and it's called a protectant actually, and it can prevent cancer, and it can actually has like anti-tumor activity. So it's like very important. As we know, sometimes insulin sensitivity or insulin resistance can lead to several cancers, and that's like one of the things that adiponectin will be able to provide some protection against that. So that's something very important. And I think it's like a preventive marker instead of a monitoring marker.
Mhm.
And I think that's like the way to go upstream. Another thing that we might want to talk about in the metabolic factor of the inflammatory situation is the trimethylamine oxide, which is the TMAO, what we know about that. So what I want to say about TMA is that it's mostly found in fish, and it is also linked to this kind of nasty fish odor. It's linked to the decomposing fish odor. So that's how we know it. So while the fish is decomposing, the TMA levels starts to go up. And once you cook it, then it goes certainly like out, and there's no more TMA. Well, there is still TMA right there. There is still some amount of microbial or bacteria that is going on in the fish tissue. But once we ingest it is when we start to metabolize it. And one of the first metabolites that it forms is TMAO when it goes, to the liver section and it gets metabolized, it produces TMAO. And right after that, we can easily found that TMAO is linked to a pro-inflammatory marker that might lead to cardiovascular disease. So something that we want to talk about the TMAO is that it's a part of the metabolic process that links carnitine, phosphatidylcholine, and lecithin, as we like to call it. So there's like some special link between eggs, meat, and animal products that might lead to the elevated levels of TMAO. So that it's something that we want to look at. There's like a very particular way that we would like to treat this TMAO situation, and that has to do a lot with creating a symbiotic balance between our gut microbiota, what we are eating, and our anti-inflammatory process that can be going on in our body. So those are like the very like deep sections of the metabolic markers that I wanted to talk about. But eventually, yes.
You had mentioned there about TMAO, and one of the things that we use TMAO is to assess also gut function.
Yes.
We want to be able to kind of determine what the endothelium and all the cardiac risks are of the arterial walls as well. So it gives us a little bit of insight as to how the gut and how the gut responds. For particular uses is the clinical significance is usually that it also tells us how potential the platelet aggregation is. So TMAO really gives us an insight as to kind of almost the predisposition and how teetering are you on an inflammatory event that could lead to a cardiac event as well. So we've added that in there. What I like to do is I like to present a little bit of the story in the metabolic side of things. And I'm going to go ahead and share my screen here and to let you also see how we actually present these particular studies. So I'm going to see if I can do a share screen here. And if it allows me to take over yours, let's see if it happens. If it warns me, we are testing it out. Can you see the screen there?
Yes, we can see it.
Okay, so what we're looking at is exactly what Anna was talking about, specifically the areas of, let's say, glucose, hemoglobin A1C. Now, what we're talking about when we're dealing with hemoglobin A1C is we're looking at the glycosylated amount of hemoglobin becomes glycosylated, which gives us in a short nutshell the ability to understand how insulin as well as blood sugar levels have been maintained over a period of 3 months back. So sometimes though glucose can actually give us a snapshot of what's actually happening. And it's useful. Not all the times is it very clinical, because it has to be fasting at times. So once you have a number that's fasting, we can make kind of an idea. Again, we're trying to figure out how the insulin is reacting, because we're learning that insulin resistance is one of the things that causes of this dynamic. So we look at that. Here we have, as Anna was mentioning, we also do the markers for TMAO to determine what is the susceptibility of an individual. We want to look at these things in individuals to see where their predisposition is. Also, we can actually we measure insulin resistance scores. We do it at C-peptides. Without getting too complex in these, there's a lot of markers that we evaluate. Now, a lot of formulations, cardiac medications that lower blood glucose, they do have a direct effect. Specifically, the low cholesterol lowering ones affect the mitochondria. And when that occurs, what we want to do is we want to see, well, if that's the case, and if they do affect the mitochondria over a period of time, what we want to do is we want to see the element and the mineral and the supplement that is directly affected by the medications, and that happens to be coenzyme Q10. Okay, so we also monitor that, because in a situation when someone's taking cardiac medication by their cardiologist, we want to make sure that their levels of coenzyme Q are high, because today we realize that if we don't, then we are messing with the mitochondria function, and we have things like neuropathies, we have things like cardiac dysfunction, atrial fibs, and we have a lot of disorders from the heart as a result of just coenzyme Q being depleted in the system. So we look at that. Now, that covers our metabolic dynamics. And as Anna was talking about that, she was pretty much talking about this particular area here. And when we look at it, we can see that we covered pretty much all these markers. Now, I want to go ahead and let you guys see that our goal is to give you an insight as to some of the clinical implications. Now, we're only talking today about inflammation, and we're only talking about metabolic dynamics. But one of the things that affects El Paso a lot is metabolic syndrome. So it's very important to do other panels like our HDLs, our LDLs, our triglycerides, our cholesterols. We want to measure blood glucose, A1Cs, and we want to measure these things because even though they may be subclinical issues, a combination of more than 3 or 4 of those earlier mentioned presentations of cholesterol, triglycerides, HDL will classify us as a person suffering from what we can now say is an early form of insulin resistance or problems later on metabolically, and we table it as metabolic syndrome. So I know Kenna is going to be discussing a little bit right now, so I'm going to stop sharing my screen, and then what I'm going to do is I'm going to give her the floor. Are you able to do that, Kenna?
Yes.
All right, go ahead and knock it out. I've stopped sharing. Go ahead and tell me a little bit about the inflammatory markers, and I'll kind of add in as I go.
Yes, so I just want to start out by saying that inflammation is necessary in the body. However, excessive inflammation is where we start to see these issues arise. So everybody needs that inflammation for small things to help keep our body in check. But what we don't want is that inflammation to start to override other things that need to happen in the body. So I have pulled up on the screen the sample lab just so we can see a little bit more of clinical references. I'll come back here to the inflammation side and I'll explain that in just a second. But I want to go through and just kind of talk about what these are. So when we're looking at these labs, we first want to look at the F2. It's going to be right down here. F2 iso, I'm probably going to say this
isoprostane.
Yes, that one. So we want to look at that one because this is kind of the ratio and the gold standard for measuring that difference between the oxidative stress and those who have oxidative stress in their life, excessive amounts. They are usually at a higher risk for cardiovascular disease and hyperlipidemia. So that is one thing that we definitely want to keep in check on that optimal range.
Kenna, I've seen this number when we measure it. We've seen it with people that smoke a lot, that have really, really crummy diets, like they have a lot of meats, and they just meat eaters and they junk food. So I've seen this. Sedentary lifestyle. Some people, because we live in the world, like pretty much all of us now, have to deal with being sitting down. So F2 isoprostane really gives us a window into those oxidative markers causing susceptibility to cardiac events. So it's very important to be able to read those. Continue, go ahead.
Yes, and thank you for that input, Dr. Jimenez. The next one that I wanted to discuss is the oxidized LDL. LDL stands for low density lipoprotein. And LDL occurs in the body when the cholesterol particles react with free radicals, which free radicals are these kind of unstable molecules that are produced as a result as a normal metabolism, but can also get out of control with a disease or if there's exposure to toxins that are happening. And so these free radicals, they cause oxidation, and that's a type of chemical that we don't want to interact with, such as LDL cholesterol. So we want to keep our eyes on this to make sure that it doesn't get out of hand, because that means our oxidative stress is going a little bit too high in that body.
I'd like to add that oxidized LDL does affect us on our endothelial area. So endothelia is the interior wall of the valves and the vessels in our heart, as well as through our body. So the type of people that have this are people that have a metabolic syndrome. The cardiovascular patients also have this susceptibility, sedentary lifestyle. So what we do is if we see this oxidized LDL elevated, we come up with certain recommendations. Some of them can be just as simple as just lowering cholesterol foods, exercising more, and even maintaining a basic healthy lifestyle when it comes down to establishing normal activity levels. But oxidized LDL is one of those things where we want to make sure that that as it forms, it acts as a toxin. Oxidized LDL is the beginning form of the atherosclerotic plaques. As a matter of fact, the oxidized LDL versions, these things are eaten by macrophages, and macrophages are scavenger cells in our body, which then turns into what I guess call the foam cells. And as we all learn now and through cardiac medicine, is that the foam cell is what ends up causing the vascular event that eventually causes a clot. So oxidized LDLs are extremely important in assessing each individual for cardiac events.
Mm-hmm. Yes. Another marker that we look for is the high sensitive C-reactive protein, or the CRP. And this in general will increase in the body when there is inflammation present. And this can also be used to evaluate the risk of developing coronary artery disease or a condition where your arteries in your heart are narrowed. And this can lead to heart attack. So we want to make sure that we keep an eye on this number as well to make sure that it's balanced with the proper amount of inflammation and not too much to reduce our patient's risk of heart attacks.
You know, when you mentioned C-reactive protein, when I was going to school back in the in the Stone Age, C-reactive protein was one of our first markers that we used. ESR, erythrocyte sedimentation rate, was also being used at the time. It's really a generalized marker and tells us that, hey, there's like walking into a house, there's smoke, you smell it, but you can't really find out where it's at. So we have much more accurate markers that we look for. But if we see C-reactive protein that is high, we know that there's a state of inflammation. This comes into place when we're dealing with an individual who has constant inflammation, pain all over the body, fibromyalgia, early markers, any inflammatory state that ESR or erythrocyte sedimentation rate comes in, we start noticing this. So people with periodontal disease, infections in their mouths, which is very common in people who have inflammatory disorders, they will have a high, C-reactive protein. People with immune disorders, people with chronic illness. So it is very important to be able to assess those as we go through those dynamics. So thank you. What's the next one that we're going to go over to?
Yes, the next one is the ADMA and the SDMA. Those are kind of not the same thing, but they're just like a factor that we want to look at to make sure that they're in check, because they are naturally occurring amino acids in the body. However, they do have a significant pre-factor of cardiovascular outcomes and mortality, especially those patients who are already on dialysis. So those are ones that we just want to, like we do with the CRP, just look at it, keep it in check, make sure that we have those markers on paper so we can make sure that they're improving and not declining.
Kenna, when we look at this one, we're looking for actually their overall nitrous oxide health. The nitrous oxide activity in their body is one of those things that we need to know that people have a good reactivity with nitrous oxide, which if it's diminished, it's our ability to deal with it. We have what we call vasoconstriction. That increases blood pressure. So what we've learned over the years is that it not only affects the ability for the endothelial function, but another area where our body gets affected is the kidney function. So ADMA really helps us kind of hone in on the fact that we have metabolite deficiencies such as nitrous oxide, and we start working with the metabolites and the dietary changes with Anna to adapt those dynamic changes as well. The next one.
The LPPLA2 is also an enzyme that appears to play a high role in inflammation of our blood vessels, and is also, it promotes atherosclerosis.
Atherosclerosis, that's hard to say, atherosclerosis.
The tongue twister for me. There have been some studies that show that this is an independent risk marker for cardiovascular disease and coronary heart disease, as well as having strokes.
Yeah, it's also the marker that we notice that starts collecting when we start having atherosclerotic plaques. So what we want to do is we want to be able to measure this and see what's happening, because that oxidized LP little a, what they call it, is one of the newest markers that is the most sensitive, though the marker is not able to be changed that much, but the susceptibility to it with our other factors in our lifestyle habits, we can change it, and it does help, because if someone has the LP little a that is high, that means that they're couched in a world where that if they have the other factors such as poor diet, poor activity, poor lifestyle, they can launch us into a state of clinical cardiac reaction that can be life-threatening, and it could look like a very healthy individual. Okay.
Yes, I was going to mention that, because if you see precisely in this sample report, we can see that the lipid panel, which is like the first thing that we see when we get a patient in risk of cardiac disease, you look at this lipid panel and you will see like, oh my God, she's doing fine. And all of a sudden, when you go to the primary factor, to the underlying factor of it all, you can see that the inflammation markers are the ones that are going to be affected. And this is going to take like a ripple effect in the lipids, maybe not today, maybe not tomorrow, but in a short amount of time, because we're looking at the moderate risk and high sensitivity CRP levels, and we're looking at all of the oxidative, the oxidative markers are kind of okay, but the inflammatory ones are the ones that are really like standing up and saying like, hey, this is something wrong, and there is something wrong happening.
Right.
So it's like
I don't know, Anna, do you remember seeing The Biggest Loser? It was like a show that was about heavy set people, and they would try to lose as much weight. Actually, the guy that was actually pushing the individuals, or the individuals that were trying to lose the weight, guy was super fit. He was incredible, and he released the information to the world. And we all know that he had perfect markers. However, when he had a massive heart attack, they tried to figure out what it was. Well, this was the marker that he had that was extremely way off the marker, in the red zones. And it's not the guarantee that you're going to have a coronary heart event, but if you don't take care of your life and adapt to the changes, potentially you are at 2 to 3 times the risk of having a coronary heart disease event as a result of this. Now, the way I see these people, I can tell, because they're usually heavy. They look swollen. They have acanthosis nigrans, which is a disorder where in the back of their neck or certain folds, the skin turns dark. Insulin resistance is the thing that usually tips me off that there's a degenerative issue along with the metabolic process. Kenna, I know you're keeping on going. I keep on interrupting, but we just want to add so much information in these things. Go ahead. What's the next one?
I appreciate all of the input. The next one that we're going to look at is MPO. And this is most abundantly expressed in our immune cells. We want this to be a controlled release when we have an infection. That way it can do its correct activities. But when it is uncontrolled,
it's okay. It's okay. We got you there. By the way, we're the only podcast that has a young child prior to school age on our podcast, so we are so totally cool. I actually, don't worry, Kenna. We're all parents, and we understand. So no worries. What I can do is I can help you out there. In terms of our lab assessments, as I can look at her thing there. What we're going to look at, the MPO. We're going to look at the different dynamics. And we're going to be making sure that we're going to be looking at lipid fractions. Now, not only are we going to be looking at lipid fractions, but we're also going to be doing a complete blood workup on the individual, such as what they call a normal chem screen, CBC, or a standard or a metabolic panel. That's going to give us information. Now, the other areas that we're going to be discussing, we will discuss thyroid action, because thyroid directly affects all the blood and every cell in the body. It's kind of like having a building without a foreman. And you know what? There'd be a lot of lazy people hanging out when not working, unless you see the foreman moving. Well, the foreman is thyroid hormone. So as we look at those things, what we see and what we can kind of adapt is to make those dietary changes. Now, let me ask you this, Anna, because I know Ken is going to jump in a few moments. When you see these kind of dietary changes, I know you have an arsenal of types of dietary changes that you work people through, such as, let's say, a metabolic or a Mediterranean diet, a elimination diet, a FOMAP diet, a cardiometabolic diet? Well, how do you approach these patients when you review their case?
Well, first of all, the first thing that I like to do is to start with we have to start detoxifying. That's like the truth of it all. And I don't mean like, okay, you need to take like this high dietary fiber supplementation. Of course, that will be like a part of your detox program. But what we want to do is that we want to take the enzymes of phase 1 and phase 2 to start working and really get rid of all of that oxidative debris that we're having in our body. So that's like the first thing. Okay, let's amp it up. Let's put some dietary fiber in your diet. Let's get the antioxidants in your body right back in, and let's try to detoxify, and let's get that liver really going on. So that's like the first thing that I like to do. And sometimes I kind of use them together, like a anti-inflammatory diet along with a detoxifying factor or a detoxifying component of the diet, because they work great and we can do it alongside which one.
I know when you say detoxifying, how long is the detox program? Are they do you have different recommendations? Let them know kind of how you assess whether it's going to be a 7-day or a 10-day or a 20-day detox. What are your thoughts on that?
Man, that really depends on the patient. That's what I call just like negotiating the diet, because most of the times the patients get like, I want to make a detox with you, and they go like, no ma'am, I can't. I won't be able to do that. And it's okay. And then I start asking like, okay, what are you willing to do? What do you want to do? And I can adapt to that level of like willingness. But most of the time it can go from a 28 detox kind of diet. And I'm not talking about, okay, you're gonna make like a 28 fast diet or something like that. It's just like the integration of that detox process to their diet. Or it could be as long as 8-day diet, 8-day detox diet, or 6-day detox diet, or even 3 days. So it could be negotiated with the person. Right now, I really think that the combination between this fast or slow detox diet and the integration with the anti-inflammatory factors of the diet, those are the ones that really work, because we want to start with the antioxidants that lead to the anti-inflammatory processes. And then we can start seeing like the wellness going on in the body of the patient. Like, hey, I'm feeling really awake right now. I'm feeling great. I felt kind of dizzy the first days. I won't lie. Those are like the first things that they mention, and I have to be very honest about it. Of course, they are doing a change in their diet, in their life. So there's going to be like some ups and downs. But at the very end of it, when we look back at the symptoms, they feel great and it's better. They get more benefits.
Yeah, the functional approach in the way we look at things is we start. I mean, sometimes these histories are quite elaborate, and our ability to help them through detoxing their lives, whether it's in a lifestyle event, it matters, or a physical dynamics that we can remove, let's say bad diets, or we call stimulants or triggers, mediators, those kind of things we got to work on removing from that. So I love that work that you do, because as a team, we can take someone that came in with let's say just joint pain and constant chronic disorder discomfort, and not just throw a pill at them and try to numb them, or try to emotionally throw some SSRI, something like Prozac or some medication of that nature to calm them down. We actually deal with the issues. Now, Kenna, are you able to go ahead and continue a little bit?
Yes, I just wanted to talk about that last marker that's mentioned,
Yes.
which is the microalbumin, and we are comparing that to the amount of creatine in the body. And so with this ratio, we're just making sure that your kidneys are good and that there's no other inflammations that we need to watch.
You know, when you mentioned that, one of the things about microalbumin, it's our protein in our body. But if we see that in the body leaking out, for example, in the urine, if it leaks out in the urine, we know that we have endothelial damage, meaning that the walls is actually letting it leak out. That indicates us it gives an indication of what's the state of health in that. Well, if we start losing certain amounts, like if you ever noticed after you eat a very highly meat or a high food or just a rich meal, you may notice that your urine's chalky. Okay. And in that situation, if that happens, it gives you an idea how that stuff is going beyond the abilities of the normal body or the endothelial structure to be able to hold that within. The leaking is a good marker in telling us what is the state of endothelial activity or strength in the body. So it gives us an insight that, oh my God, this person is being very porous, there's damage. The measures at the kidneys for the creatinine is important, and microalbumin, it also gives us an idea as to how the overall circulatory endothelial lifestyle or the activity or their health is, so to speak. So microalbumin is very good. Guys, today was a very exciting beginning. As you guys can see, I'm going to go ahead and take over the screen here so I can kind of end this. It was just a little short and sweet. Hold on, I don't want to cancel, stop. Okay, this will stop others. Okay, you did, thank you. Okay, so then I'll share my screen. As we all learn in this process, we'll have to work as a team. Zoom has made it good for us. Can you guys see that screen again? So what we did is we discussed the metabolic components. We're going to be discussing the inflammation continuously and going deeper and deeper in the concepts. I think our next one is going to be covering lipids and inflammation so that we can kind of cover these topics and seeing what it matters and how it means something to our patients. So I appreciate you guys. Listen, you guys did good, and Landry did well too. Yeah, Landry, she's doing well. So any thoughts on anything, just give me a call. We'll be here. We'll answer. Anna's ready to help you. We use very, very much, we're in tune with the virtual world, so we can come into your computer at your house or your phone, and there's no real reason why we can't communicate with you, particularly regarding issues and that may be affecting you or family loved ones. So God bless. Thank you very much. Thank you, Anna. Thank you, Kenna, and look forward to talking to you guys on the other side, and we'll chit chat with you during the week. God bless. You have a good one. Bye-bye.
Bye.